on my device. It's okay, right?
Yes, it's okay. We can see the full thing.
Okay, perfect.
Rolika, cringe for me.
We are live.
Good evening, everyone. Welcome to iFocus Online, lecture 268, and this is the Uvea session 9. And it happens to be the Dr. Somasheila Murthy ma'am, and she's the showstopper of this year, I would say, as this is the last episode of 2022, as we step into 2023 with new hope. And ma'am will be speaking on anterior uveitis, and I request Jyotirmay Biswas sir to please introduce ma'am.
It gives me a great pleasure and privilege to introduce Dr. Somasheila Murthy. You can introduce many ways Dr. Somasheila Murthy. I feel that he's a very good organizer, and he's a member of the scientific committee of All India Ophthalmological Society. She has done a very relevant and important work in scleritis in particular and anterior uveitis, viral anterior uveitis. She specializes in ophthalmology from Mumbai, and she did a clinical fellowship in cornea from LVPI and uveitis and ocular pathology from Doheny Eye Institute, one of the prestigious eye institute under Dr. Narsingh Rao, Professor Narsingh Rao in the University of Southern California, Los Angeles. Currently, he is the head of the cornea and anterior segment services and consultant uveitis services, LVPI Hyderabad, one of the apex eye institute in the country. Her areas of clinical expertise include disease of the cornea, anterior segment, uveitis, and ocular inflammation. She had 60 publications in peer-reviewed international and ophthalmology journals. I have read several of them with a lot of interest, particularly the review article which she has read in the she has published in Indian Journal of Ophthalmology was a great work. Her passion for teaching and takes an active interest in training program, phacoemulsification, teaching programs on the DNB students. She received, no wonder, the Achievement Award from the American Academy of Ophthalmology. And with this, I welcome the last lecture for the uveitis for this year, 2022, Dr. Somasheila Murthy, and she will be talking on a very important topic, anterior uveitis. I'm really looking forward to listen to you, Somasheila, and I logged in 15 minutes before.
And I must put an erratum over here that ma'am's publications have now increased from the 60 that is mentioned over here to 185 plus publications.
Yeah.
So that's like an error from our side, but ma'am, may the publications increase more and more in number. We would love to read your manuscripts. Over to you, ma'am.
Thank you very much. I think that it's almost literally, I have tears in my eyes to be introduced by Dr. JB. That itself has made my year end 2022 so great. Thanks for that very, very generous introduction, Dr. JB. And vice versa, I think we are sorry to take up more time, Rolika, but we must introduce Dr. JB as well. Is Abhilasha doing it? Shall I do it? Who should do it?
Ma'am, please do the honors, ma'am.
Oh, yeah. So Dr. Jyotirmay Biswas, he is the director of uveitis and ocular inflammation at Shankar Netralaya in Chennai. We did say that he doesn't need any introduction, but he must, because he is the one person who's a passionate researcher, a compassionate clinician. Patients sing his praises because I know we share some common patients. He sees almost, I think, 3-4 days clinics, and then he does research. So in some ways, I followed some of his footsteps. He did his fellowship with Professor Narsingh Rao way back, and his first fellow from India at least. And after that, he came back and he did ocular pathology and of course uveitis. And he's a trained pathologist as well, which he was doing for several years. Probably he still looks at slides as well. He's nurtured and mentored many fellows. He has a very active one of, I think, the first uveitis fellowship in India. So, and then for over 20 years, I think now, so many fellows that he has trained, both national and international. And indirectly, he has contributed and trained and taught many of us through all his lectures, his papers, and whenever we interacted with him directly. So I've learned a lot of things from Dr. JB. In fact, you'll see that even slides he's generous, he shares them. So you'll see that in my presentation as well. Apart from all of this, he's such a warm human being. He cares about people, and he has a lovely wife and daughter.
Thank you. Thank you.
Thank you so much, ma'am. That was actually a very warm welcome. And I would like to say, sir is extremely down to earth. I had the opportunity of meeting him last month, I guess. And of course, it was a wonderful experience, sir. Thank you for coming over, sir.
Thank you. Over to Somasheila.
Yes.
So as I share my screen,
yes, ma'am.
Just a quick word about today's topic. So I want to make it as interesting as possible and maybe, stimulate everybody. So I'm going to present case presentations in anterior uveitis. Going straight into deep diving into my presentation. So let us look at certain interesting aspects of anterior uveitis. What I want to bring forth, and you'll get the answers to this question, is the first scenario is the commonest anterior uveitis entity, perhaps more than 50%. The second scenario is the often missed or misdiagnosed, which constitutes about 11 to 15%, depending on the publications. The third scenario is something that is underdiagnosed, probably about 10% in terms of anterior uveitis, but it's probably much more common than we think it is. And the fourth scenario is an extremely complex and challenging situation of pediatric uveitis. The fifth scenario is all the other causes, which could be masquerades, such as infectious causes or foreign body causing anterior uveitis or tumors and so on, which is about 2%. So that I'll not bring in today's presentation. So I'll describe the case, and then Dr. JB will sort of give us some discussion points, and then I'll go through the prepared discussion that I have for each case. This is a sort of a no-brainer, easy case. It's a 24-year-old male, sudden history of redness, watering pain for 3 weeks since he comes to us. And when we examine the patient, we see that his visual acuity has decreased. There's 3+ circumcorneal congestion. There are fine chaetic precipitates, though you can't see in the picture. But what you can see is that the florid reaction in the anterior chamber, because there's even a little hypopia on here, and there is sort of a membrane on top of the pupil, or on top of the lens. And the pupil does not dilate because it's bound down because of some synechia. So what do you think this is? Then the patient comes out with his history when we ask. He says that he is already diagnosed, in case you were also thinking the same thing, you're right, as HLA-B27 positive since 4 years. And he did have similar episodes. For the past 2 years, he was on treatment for his systemic disease, which he had recently stopped because his rheumatologist felt that his systemic disease was now okay. He barely had any symptoms. And then after stopping all that, he comes to us with a uveitic episode in the eye. So the diagnosis, if you remember how to diagnose uveitis, you think of the pathological type, whether it's granulomatous versus non-granulomatous. Think of the anatomical type, whether it's anterior, intermediate, posterior, or a panuveitis. And if you have specific etiology, like in this case, so you can add the etiology also. So you have a non-granulomatous anterior uveitis, and this is the HLA-B27 type. If you didn't have HLA-B27 history, then you would have said that in a young male patient or something like that. So how do we manage this? We started the patient on prednisolone acetate eye drops every 1 hourly, and we immediately started atropine eye drops because we saw that there were so many, the pupil was bound down, and we asked the patient to use a steroid ointment at bedtime. The patient was followed up 48 hours later. He was much, much better, so we could taper the therapy, and we kept following up the patient till there was complete resolution of the symptoms. So this was on follow-up. What I've tried to capture here is the flare, which is the protein that has changed, and you can see that because of Tyndall effect when you make a small slit and look into the anterior chamber. And as the pupil dilated very nicely, you can see that the little pigments on the iris, which are the former posterior synechia, which we could break successfully. So coming to discussion about this case, and then maybe Dr. JB, if you could start with the discussion for typical HLA-B27.
Yeah, actually, they give the history of recurrent attack, alternating between the eyes. And I'm happy that you told about atropine, though the textbook says that in anti-uveitis you put homatropine eye drop. Fibrinous anterior uveitis, I find that the atropine is necessary for few days. The reason is that it breaks the posterior synechia, and you cannot get it down with the homatropine eye drops that much. And this sometimes is that this history of taking a low backache pain in such cases is quite important, because sometimes it's undiagnosed spondyloarthropathy may be found in these HLA-B27 positive cases. I think this is quite well managed, and giving that predport eye drop every 1 hourly. I sometimes give even every 15 minutes for initial few hours. These are my points.
Of late, I do use diflupred in patients, maybe too early, but then I make sure that I take it off and then go back to predfort once inflammation settles. Because these are young patients, and I feel that the IOP spike or the cataract formation can be more with diflupred. So HLA-B27 is a common entity. So whenever you have a young male patient, like the case I described, probably the only test that you may get done, because in India we have patients with financial constraints, is to get an HLA-B27 test done. Most of the labs do it by flow cytometry, which is an easier test, and you can get a very sort of quick result. But if you have typical symptoms and signs that you see in the patient, maybe systemic also, and HLA-B27 has come negative, then you can ask for PCR. So HLA-B27 testing by PCR in those which have initially come negative or indeterminate. And sometimes you will be surprised that you'll get the positivity on PCR. So chase the diagnosis just a little bit. Why? Because once you know what it is, you know that it is easy to treat. It needs topical steroids. Very rarely does it need oral steroids. We've seen often that practitioners do start oral steroids for these patients, because as soon as the patient comes, they just start that. I think very rarely you require it, maybe less than 5-10% cases. And in some cases, if the patient continues to have recurrent episodes, and they're not under rheumatologist care, but they have ocular recurrent episodes, more than 3 to 4 a year, so they're continuously on drops, then in these patients, you might have to resort to using oral immunomodulator therapy. And of course, oral immunomodulators are also used in patients who they have established systemic disease. The second slide is, this is the case that I was alluding to earlier, shared by Dr. JV, slide long back. And this patient of his has the typical recurrent anterior uveitis with even hypopia. There is a cataract here, and they can keep having it throughout life. This is a patient of mine. You can see that he has ankylosing spondylitis, and he's quite elderly, but he's in his mid to late 70s, but I see that he continues to have inflammatory episodes. So when I had to operate on this patient with ankylosing spondylitis, that's when it becomes very problematic. So the patient cannot sleep straight, and he has to have this the bed of the operating table folded like that. So we have to really search for a bed like this, and the cleaning has to be done like this. We have to give a peribulbar block in this position. Even his legs, he has to keep them folded in order to balance his head. And even the phaco that I had to do was sort of standing, because otherwise I'm tall, but I still couldn't reach by sitting on a chair. So I had to stand and complete the phaco. It's a good thing that you really literally need only 1 foot switch, only 1 foot to operate the foot switches. So it'll be hard to put both your feet up in this situation. And finally, you can have a good result. So it's better to operate on these patients early. That's what I learned, rather than wait for them to get an advanced cataract. So Abhilasha, any comments from you before I go to the next case?
Thanks, ma'am. It was an excellent talk about HLA-B27. And as sir rightly pointed out, that early morning back pain and back stiffness, which becomes better with activity. And I had read that about 12% patients do not have any systemic disease at presentation. And as ophthalmologists, it is our role to diagnose these patients and refer them to the rheumatologist so that they don't develop deformities. That's the only point I'd like to add. For ophthalmologists, we should be very careful. For fibrinous uveitis, look for HLA-B27 and get a rheumatologist opinion about the back so that the deformities can be prevented.
One of the important things is that nowadays is the rheumatologist in their sleeve has got many more drugs, which can really rehabilitate these patients very well, treat and rehabilitate these patients. So don't really refrain from sending them to the rheumatologist. You'll be doing a good job, holistic approach.
Just off the cuff, so sometimes we send the patient to the rheumatologist saying that they have recurrent anterior uveitis episodes. Then we see that the patients are just started on HCQS or SAS. And then that becomes a little frustrating for us because then, of course, sometimes you are forced to have a dialogue with the rheumatologist. But what do you think about that, Dr. Jimmy?
I think that HCQs is a drug which I tell rheumatologists that not to give that because they have got the macular toxicity. And sulfasalazine, to my mind, is though the rheumatologists do not agree all the time, is not a very strong drug for uveitis patients subsystemic association. Methotrexate would be a better drug.
Yeah, so what my point here is that everybody should look at what the patient is receiving. Just because you're under the care of a rheumatologist, that may not be adequate. So, by the way, Dr. Abhilasha Baharani is a uveitis specialist practicing in Hyderabad, and she also has a lot of laurels already in her young career. She has won the Best Paper Award at various uveitis conferences. So you have a great specialist here with you, and she also does a lot of cataract surgery in uveitis patients.
Thanks, ma'am.
I wanted to move on to the second case. So I have 4 cases, mainly, I think 4.5 cases. So maybe 10-15 minutes per case, and then we'll take comments. If there are any, we'll take questions and so on. I think that's the plan. So the second case is also a young male patient, but he's not the same as the first case. He complains of sudden vision loss, and he says that he's noted a white reflex in his right eye since 3 weeks. And he could not remember any history of trauma, and there was certainly no redness which was antecedent to the vision loss. So what we see here is a very nice white eye, quiet eye. And I'll come to what the iris has. But what you can note is that there aren't any posterior synucleate, unlike the previous case. And he has a total intumescent cataract, which you can very easily see. It's very soft cataract. So this picture, the second one, is trying to pick up the keratic presbytate. So you have sort of medium. There are some fine ones also, but they're quite white-looking keratic precipitates, and they're scattered all over here. I wonder if you can see them in the retroillumination. And there are some of them going even higher up, which is kind of difficult to capture. So you have to imagine when I say that, even higher up, you have these keratic precipitates, not just concentrated in the inferior triangular area. So what do you think this could be? No guesses. If Abhilasha is going to guess for us, no credit to her. You have a patient with intumescent cataract, findings of medium-sized KPs distributed above the midline also. So this is a classic case of, so it looks like it's a mystery. Yeah, so Abhilasha gave up the mystery. Let's go to the second case in the same series. This is a 36-year-old lady. She says that she has progressive decreased vision, not sudden decreased vision, and she has this whitish pupillary response since 1 year. And she underwent extensive tests. She spent twice of 20,000 rupees. She had an AC tap done. She underwent vitreous biopsy. She received oral steroids, topical steroids, posterior subtenon steroids. She got an injection of Ozurdex. And now she was on immunomodulator therapy when she came to us. So there's nothing relevant. We asked all sorts of history, but nothing was relevant. And all her baseline investigations that you do for uveitis were all negative or normal. And the vision was fairly low in the right eye, the one in which she had the problem, and the left eye was almost nearly normal. So this is again the slit-lamp image of the right eye. This whitish hue is because she again had a cataract, a little similar to the previous patient. And again, you can see some discrete, slightly pigmented keratic precipitates in the midline, just lying over here. And her pressures are always normal. So we had the history. And then if you look at this image, so these were that isolated looking small pigments, but she also has a lot of other keratic precipitates which are going above the midline. So both these cases that I described are nothing but Fuchs uveitis syndrome or Fuchs heterochromic cyclitis. In this, vitreous opacities are the frequent features. And then you have those almost granulomatous looking keratic precipitates. So when the patient lands with us, the first thing that most clinicians think of is either intermediate uveitis or a granulomatous uveitis. And then we start falling into that trap of getting multiple investigations done. And like this previous patient had, starting therapy, and the patient doesn't respond because the AC reaction and the vitreous opacities don't go away. So we continue to give more and more and more medication, like the previous case that I just presented. Also, when the patient comes with sudden onset white reflex, like in the first case that I showed you of these two series, then we often think that it could be a traumatic cataract, because how can suddenly just a young patient have a rapid intumescent cataract? So in those cases, we must look for those fine or those stellate looking cataract precipitates. So these are the two missed diagnoses that we have. Either they think it's intermediate uveitis, or sometimes it's a young patient, so traumatic cataract. But these are cases of Fuchs heterochromic cyclitis or Fuchs uveitis syndrome. So Dr. JB, your comments before I go on to
yeah, one of the important points which I wanted to highlight to everybody that is the Fuchs uveitis, the disproportionality, the cataract is disproportionate to inflammation.
Right.
Is a sudden. So,
Right.
and there is no synechia. And this will always give suspicion for a Fuchs heterochromic iridocyclitis. KPs will not be mutton fat KPs, but can be medium-sized also.
Right.
Small to medium-sized fine stellate KP. And in our country, we don't see iris heterochromia. I have not seen a single case of iris heterochromia in any of the Fuchs uveitis because it's so difficult in the pigmented population.
We do see, if you keep comparing the two eyes,
Yeah, you can
lighter,
see that. Yeah.
and you can see the reticulate pattern because of the loss of the pigment of the clear layers.
Yeah.
So those things you can see. Sometimes you can see crystalline deposits or granulomas on the eyes.
Yes.
So Abhilasha, your comments?
Just one point that these patients don't give history of redness.
Right.
Yeah,
So
yeah.
That is a very important history to ask for, that whether patient had any history. So they will say that, and most of the time they say that when I close the other eye, then I realize that I cannot see in this eye. So that's the typical history that they give. And of course, no history of redness. And sometimes there might be increased intraocular pressures also in these patients, which is a common thing. And post-operatively, they have to be monitored for glaucoma, because they have a high propensity to develop high IOP.
Patients with Fuchs present only if they have loss of vision that is due to the cataract, or if they have some disturbance due to the vitreous opacities, if the disease is starting for them. Or it's just coincidentally, they come in for a normal checkup and then we realize that this is what they have. Otherwise, they don't come with classical history of redness, photophobia, and so on, which you attribute to other uveitis entities. And they do have low-grade inflammation, 1 to 2 plus cells. Whatever you do for these cells, like I said, you start steroids and all that. It may temporarily decrease, but again, the minute you take off the medication, you will have the same amount of low-grade inflammation. So the good thing about Fuchs is that despite having this inflammation for so long, you don't see cystoid macular edema, or you don't see other destructive problems due to chronic inflammation. So for some reason, it seems like the ocular tissues, the rest of the ocular tissues, all the ocular tissues except the lens seems to tolerate that low-grade inflammation. So it affects younger individuals. Dr. JB, what would be the oldest patient you've seen where you think it's Fuchs?
So around 40, 50, 45 or 50, but I don't see that older patients much in the Fuchs uveitis.
Right. So because it's in the younger...
This is the young age group.
Right.
Young.
So that is probably because this is attributed to rubella virus. And those who received rubella vaccine, so that would be up to the 40s age group. You know, beyond that, older patients than that may not have received rubella vaccines when they were pediatric. So I think that's why you don't see it in older individuals in that way. In the elderly population, you probably don't see it. So they have minimal symptoms, as I mentioned, and then based on what paper you read, 2 to 11% of all uveitis. So this was one very puzzling, challenging case we had. This is shared by Dr. Sangwan. And this patient we saw when he was an LVP with us. The 13-year-old child who was now diagnosed to have bilateral intermediate uveitis and was going to be put on oral steroids, was given a very poor prognosis. So the patient's parents were extremely worried. What you can see here is that The iris color looks a little abnormal. There are these large multiple kertic precipitates again crossing the midline. That is a clue. And if you look carefully, this is the high magnification, you see these little sort of moth-eaten kind of looking nodules on the pupil as well as on the iris. So very classical. We see them in a few patients of Fuchs. So this was nothing but Fuchs, and it can happen even in a young individual like that. So it seems to have a slightly larger spectrum in terms of age. Bilateral is less common. And then, as I said, no CME and no posterior segment manifestations. And the lingering inflammation will be there despite all therapy. And rubella vaccination is correlated to it. In the US, when the patients who never underwent rubella vaccination in that age group, when they studied epidemiologically, they saw that there was no Fuchs in those patients, whereas the patients who did receive vaccination, they had a higher incidence of Fuchs, and they concluded that this is due to post-vaccination in that study. And Professor Anne Rotova is maybe one of the first few to talk about the role of rubella virus in classic Fuchs uveitis. Of course, Fuchs can have its mimickers, which are other viruses, but the classic Fuchs, the ones that I'm describing throughout right now, is the one with rubella association. So you can have cataract, as Abhilasha mentioned, you can have glaucoma, but never have synechia. If you have synechia, then it's not Fuchs, it's something else. And you can have opacities also. And this is on when you do a specular to look at the stellate kertic precipitates, you can see that the edges are really sort of stellate, so star-shaped or spreading in that fashion. And this is nothing but the inflammatory cells which are stuck on the corneal endothelial cells. And when I was going deep dive reading into in Fuchs, why the corneal endothelial cells are they have these deposits, they have the stellate kertic precipitates. And there are some papers that suggest that maybe there may be some development of antibodies against the corneal endothelial cells in this disease. So that was just a little extra information for you. So that was about Fuchs. Any other comments, Dr. JB, Abhilasha, before I move on to the next scenario?
No.
Okay. Rolika, any questions so far from audience, or we can move on?
Ma'am, the questions we can take in the end because they're slowly coming in.
Okay,
so
fine.
We have sent few questions to Abhilasha, ma'am. We'll send more, ma'am, as and when they keep coming.
All right. So the third scenario, we have a 35-year-old lady, recurrent episodes of redness in 16 years now. And by the time she came, she had secondary glaucoma. So she is diagnosed as an entity called Poschner-Schlossman syndrome. It's quite a mouthful to say. What is the Poschner-Schlossman syndrome? So in addition to other history, she had also undergone LASIK 9 years ago for very high myopia. And then that was fine. She was doing well. Then she developed a cataract because of the recurrent inflammation or maybe because of steroids. So she underwent surgery for that. That was also fine. She was doing well initially. So her visual acuity in the unaffected right eye was absolutely normal 20/20. So we'll not discuss about it. And in the left eye, when she came to us, visual acuity was very poor. It was just counting fingers vision. So this is what we see for her. So we see a patient with a sort of a mid-dilated pupil. Don't miss these isolated, very innocent-looking kertic precipitates, rounded, white-centered looking, and there are multiple of them. They go all the way up here also if you look carefully. And though you can't see it in the second picture very well, but she has a LASIK flap, and there was some fluid in the LASIK flap because of the high pressure. So this is, you can see very well on the OCT. So this kertic precipitates are hanging on there to the endothelial cells, as you mentioned earlier. And this is the anterior part of the OCT or the epithelium. And then this is actually the LASIK flap, anterior portion. And in between the LASIK flap and below the epithelium, you have this interface fluid. So what this patient has is secondary glaucoma, of course, and she has sort of a very long-standing inflammation or uveitis. Unfortunately, her glaucoma had advanced and her disc had become 0.9 cup. So it was not a great scenario, seems, for her to be with. So based on her clinical appearance of those kertic precipitates, the history of recurrent episodes of inflammation with raised IOP, we diagnosed her as CMV uveitis or keratouveitis, or sometimes we call it CMV anterior uveitis with secondary glaucoma. But we were not sure, so we did an AC tab, and we sent the fluid sample for PCR, and we were planning to start the patient on Valgan once we get the results. So not only was she positive for CMV with conventional PCR, but also real-time PCR was positive, as well as with very high copy load. So in spite of having 16 years of history, the patient continued to have CMV anterior uveitis, and the viruses were just probably multiplying because this real-time PCR was telling us what's the load of the disease in her eye. So we started the therapy for her with valganciclovir, initiated 900 milligrams 2 times a day for 6 weeks. And then because it's very expensive, so we can't keep the patient even cost-wise very long on it. So we then stepped it down. We wanted to keep her as long as possible, but I think after 3 or 4 months, she stopped the therapy. She underwent a trabeculectomy for her glaucoma, and then postoperatively she maintained the eye pressure, and her vision improved to 20/100. This is rapid resolution of the fluid in the interface, if you remember the previous picture. And even the cornea looks less steamy or less edematous. So ultimately, the condition resolved once we started her on the treatment. But we know that these conditions can recur. So far she's doing well. She's almost 2 years out from the treatment. Dr. JB.
I just find that there's a kind of problem of these patients is how long to continue the treatment.
Right.
Because we have seen that patients are doing well,
right,
and become so happy and then comes back again with the recurrence.
Right.
So the jury is not out that how long to continue the antiviral treatment, like anti-CMV treatment. And one can find out that quantitatively doing the PCR, repeat PCR, you can see that CMV copies have come down or disappear. That can be done.
Okay. Do you do the same thing, Dr. JB, like you do a tap for all suspected cases?
Yes, 100%.
And what is the, so when you have all the classic signs, clinical signs, and you can sort of literally sign out on the diagnosis, but
yes,
then you have a negative PCR in these cases.
Still, I believe in my clinical diagnosis and put them on ganciclovir.
Yeah. So
when I see the pressure is in the range of 40, 50 and see this kind of coin-shaped precipitates, I make almost my mind that I'm dealing with viral uveitis, probably CMV anterior uveitis.
So the message here is that you, based on the clinical signs and of course the long history that we mentioned, so we can come to a conclusive diagnosis, because I'm sure many people won't have access to a lab facility which will do a very reliable PCR. Even with us, the positivity rate is just 50%. So I don't know, even when you can say that it must be active, but sometimes you just get a negative result. So even if it's negative result, exactly as Dr. JB said, that based on our clinical thought process, we go ahead and start the treatment for the patient. So as was described by Dr. JB, you have either coin-shaped catechy precipitates. Coin-shaped are almost sort of pathognomic for this condition. They can also be linear, they can be small to medium size, different types, but if you have this coin shape, then it's supposed to be pathognomic. And they have very mild AC reaction, but super high IOP. So when you have such a situation, think of CMV. It can either also cause corneal edema, so it has a predilection for the cornea, so you can label it as CMV endothelitis. But when the cornea looks relatively uninvolved and more of a low-grade anterior uveitis, then you have the anterior uveitis component, and typically you'll have secondary glaucoma. And these patients, before you say the cornea is uninvolved, do a specular microscopy or do a confocal microscopy to see the cornea, and the owl-shaped cells or the owl-shaped changes in the corneal endothelial cells is classical for this. So the other viruses that are very commonly attributed as etiological factors include HSV1 as well as varicella zoster virus. And some of the clinical features can help us distinguish between the three, but we can do an aqueous tap. As I said earlier, it may come negative. So in that case, you can resort to clinical features. If you're not very sure, then you can always start the patient on acyclovir or valacyclovir, because HSV and VZV, both of them will respond well to that. And if you don't get any therapeutic response, then you'll have to switch to an expensive drug like valganciclovir. So that is one way of approaching it. May not be the correct way or the only way. Abhilasha, any comments, or Dr. JB, any more comments?
I use Val's acyclovir. Is it a little costlier, but
Yeah,
it's more comfortable 3 times daily.
3 times.
1 gram.
Yeah.
And then I reduce 1 gram 2 times daily sometimes, and then 1 gram once daily. Keep
And
it for longer.
and
I give minimum 90 days treatment.
Okay. So based on our keratitis experience, where we use acyclovir literally for 1 year or 2 years.
Yeah, sure.
So here we also stretch the theory, and we sometimes tend to keep the patients on longer dose, 6 months and so on, because they also come back sometimes with recurrences. So moving on to the fourth case scenario, and I'm trying to keep this entire presentation very sort of light and bright because it's night, so that you don't feel very sleepy. So this is about a difficult situation. 11-year-old boy. He comes in as 11 years. Whenever I'm in the Uvea clinic and I see a child coming in, my heart just sinks. So this child had decreased vision starting a few months, or maybe noticed since a few months. So at the point when he enters, his vision is 20/30. He has about 1+ low-grade inflammation in the AC, but he already has iris bombay and posterior synanche. So it's not acute history, it's probably chronic, which typically happens with the pediatric uveitis. So he has undergone baseline workup. They have done investigations to rule out GI. They've done investigations to rule out sarcoidosis, including HRCT and thing of the chest and so on. And HLA-B27 anyway was negative. In the HLA panel, what they had was HLA-B5 positive. So already the child was on oral steroids at presentation, probably because of the severity, and topical steroids, and there was a steroid response, so anti-glaucoma medication. We could barely see the fundus and because of the pupil not dilating. So we diagnosed for the time being as non-granulomatous anterior uveitis. And this is the clinical pictures of the patient. So in fact, this patient has also visited Dr. JB once, though he may or may not remember. So this was a little bit later on. The patient, because remember I said iris bombay. So the patient was actually it was an angle closure kind of a glaucoma. So instead of giving anti-glaucoma medication and assuming that it's steroid response, what ideally could have been done, a gonioscopy or an assessment of the angles and a YAG laser peripheral iridotomy. So here the YAG iridotomy was done and enlarged. But for the other eye, we couldn't get the YAG, we couldn't do that. So this was a surgical iridectomy that was done. So multiple attempts were tried at YAG, but they couldn't get it, our glaucoma colleagues. So after doing the laser peripheral iridectomies for the patient, at least the glaucoma part settled down for this patient. So cut to chase now, in the sense that we're fast forwarding. So from 11-year-old, suddenly I've been following up the child every now and then, many times in the past 6-7 years that I've been seeing him. Whenever he was not improving, I would take the help of Dr. JB and have the child visit him as well. So in 7 years, what we have done for him is that we have maintained his vision almost at that same 20/30 stage. We started off with using methotrexate right away, because we knew that we would have to use this for long term. And the past 2 years, we had started the patient on adalimumab, which is one agent that can be used with some amount of safety margin for pediatric patients, and he received 7 infusions. He seemed to get better. Then we did cataract surgery for one eye, and subsequently, I've not updated this. We also did cataract surgery for the other eye. And the first eye where we did cataract surgery, also we did a partial vitrectomy because he had chronic vitritis with very turbid vitreous opacities. And since then, we also started a second oral agent. So the patient is on methotrexate as well as MMF, and also received ADA 7 infusions, and has undergone bilateral cataract surgery, one eye vitrectomy, still maintaining 20/30-ish vision and doing fairly well in that way. So the child, now no longer a child, he's finished his primary as well as secondary schooling, and he is now going to join engineering. So that is a good result for this patient, but very challenging. So close to 50% of the patients with pediatric uveitis turn out to be anterior. And when it's anterior, quite a vast segment of them could be JIA, or some of them could be HLA also. So rule out those two. The idea now for young pediatric patients is to avoid oral steroids. And we have so many other agents available to help us do that. So start safe immunomodulator therapy very early on. And remember that these pediatric patients have a high predisposition to cataract and glaucoma. At least cataract we see almost in all of them. So that is one thing that, again, we have to deal with. So Dr. JB, over to you.
Yeah, I just wanted to highlight is that I'm extra careful about the pediatric uveitis cases because they've got the long life ahead, and any kind of cataract, glaucoma, that becomes a very major issue. So I almost beg the parents to come for regular follow-up and to put the drops, compliance kind of thing. And the parents are always protective, and they do not want that. They read the internet and see that immunosuppressive can produce some kind of side effects and all, cancer, and is basically used for cancer and all. So they are very protective. So you have to spend time to convince them. Recent studies by Dr. John Kempen has shown that they have got very little chance of developing malignancy due to the immunosuppressive agents continued use for months together or years together. Methotrexate is quite safe in children and can be given for very, very many years till they. Many of my patients now doing engineering or medical become doctor also. These GIA patients, and what I have followed them is quite good. But I've seen some patients has been not really followed up. One eye lost, another eye have to really struggle to keep the vision and inflammation under control. They can develop glaucoma, they can develop hypertony. It's really a challenge. Close follow-up is very important.
So now can we take the questions? Dr. Somasheila, there are quite a few questions that postgraduates have asked.
Yeah, so I just have my conclusion slide. So just the answers to that. So the commonest anterior uveitis that we deal with is HLA-B27 in general. The one that is often missed or misdiagnosed is Fuchs, which is missed and misdiagnosed as other things. The one that is underdiagnosed but is very, very common is not very, very common, but probably common is viral. And I talked about pediatric uveitis, the main challenges being in management, as you saw, because of its multiple complications. So with that, I've come to an end of my presentation at least, and so we can move on to questions, and I'll stop sharing my screen.
I just wanted to tell you one of the important causes also we should not forget or miss. That's the muscular syndrome, which Somasheila has told that she won't be discussing, but that's really the leukemia or retinoblastoma can produce hypopia and uveitis. And that's also quite important to distinguish because it can be life-saving.
Yes. So we'll go to the first question. Clinically, what are the differentials that can be thought of based on type and distribution of KPs? So what are the differentials based on type and distribution of KPs? Dr. Somasheila, you'd like to take this question?
Okay, maybe I could have put that in my presentation. So first of all, based on distribution of KPs, look both at whether it's granulomatous or non-granulomatous, and whether the distribution is in the triangular fashion, the arched triangle, or is it diffuse, or is it just in some certain area, some small little area. So I kind of discussed about it. So if it's in the arched triangle, then it's going to be more conventional kind of uveitis.
Yes.
Say HLA-B27 non-granulomatous. If it's diffuse, then it's going to be viral. And a few other entities, like a very severe uveitis, can also have diffuse cetic precipitates. So don't forget to see the retina. I think you can have it in toxoplasma also.
Yes.
But not anterior uveitis, but you might miss it. So you have to see that as well. And even VKH, you can have multiple. So any profound uveitis, you can have a diffuse, it overwhelms. So you can have that in acute stage. But traditionally, if it's only anterior uveitis, you examine everything else, then these are the two differences that I can think of.
JB, sir, would you like to add?
I have got two cases of diffuse keratic precipitates, though it's very, very uncommon, not for the postgraduates.
Right.
But, the diffuse keratic precipitates patient presented, and I could see the fundus due to the haze. But when the fundus when the haze cleared up, I could find out the toxo lesions in the back part of the eye. And one patient has got so much pigmented KPs, and that's recently which I've seen. And then we should keep, as Shamsula rightly told, we should keep in the back of the mind, not as a common cause, toxoplasma producing diffuse anterior uvei KPs, diffuse KPs.
And of course, if you have some infectious focus in the anterior chamber, maybe if you have post-traumatic infectious or foreign body, it overwhelms. So you can have diffuse keratic precipitates, or you can have localized KPs around that area. So Dr. JB had one very famous case of fungal abscess, I think, and that had a picture like that.
Yeah.
Dr. Rolika, would you like to add something about masquerades KPs?
Ma'am, masquerades like in the ocular tumors that we see?
Yes.
Ma'am, we have seen cases of tuberculosis as well. The patient who has been diagnosed as like a lymphoma, but actually the clinician probably did not notice the small KPs anteriorly. It was the patient presented to us with a choroidal mass, and it was told that the patient is actually a patient of choroidal lymphoma, whereas the small KPs were present. So that was a case of tuberculosis. So I wouldn't say it's masquerading as an ocular tumor, but of course the presentation has to be looked into. We also see retinoblastoma presenting as a hyperpyon. We also see cases of choroidal metastasis presenting with an anterior uveitis. So, and we have seen, so these are the cases that I have seen often in our cases. In fact, choroidal melanoma also presented with uveitis. And we have had a case of medulloepithelioma, of course, presenting as uveitis. So these are cases often that we see, that I have seen that have been missed.
Thank you. I'd just like to add that in sarcoidosis, you see granulomatous KPs very close to the angle or in the angle.
Yes.
And sometimes when the patient has already been started on topical steroids, you may not see the KPs on the cornea, but if you do a gonioscopy, you will see small granulomatous KPs in the angle. So that's the discussion about KPs. The next question is, can you please elaborate on white-eyed uveitis? White-eyed uveitis. JB sir, would you like to take this question?
One is that JA, Fuchs, and then we should not forget the basets can have cold mobile hypopyon. And if you see the fundus, you will be seeing that disc is pale, retinitis, and retinal vasculitis. That also is a white eye, and then muscular syndrome. Retinoblastoma presenting as hypopyon.
We also have white eye uveitis in intermediate uveitis.
Yes.
Sometimes they don't have much of symptoms anteriorly.
Yes. So in this one sentence, we have covered this question. The next one is, what may be considered as indications for aqueous tap in anterior uveitis?
Right.
Dr. Somasheila.
So yeah, it looks like they preempted my presentation or something like that. So one is suspecting viral, and the second, I don't know if you would do it if you're suspecting leukemia, Dr. JB.
Yeah, we'll do it because that it indicates CNS lymphoma, CNS leukemia, CNS spread, and the treatment is completely different. In when you find out the anterior chamber aspirate of the leukemic patient, the bone marrow is negative, that CSF tap is negative, and then if you still see the hypopyon, it can be seen that as a neuro is the CNS spread of the tumor, and they require the treatment, a different strategy of the treatment therapy protocol. I will do the AC tap. I have done AC tap for few cases.
Right. The other infectious cause I can think of is when you have a brownish kind of a hypopion, and these patients can often be tubercular. They can have tubercular that you can diagnose based on that.
So we have described in American Journal of Ophthalmology case reports pigmented hypopion. Ratnam also has published a case of pigmented hypopion due to the tuberculosis. Another cause of pigmented hypopion is Listeria infection.
Right.
Yes, so the next question is on hypopion. So part of it has already been answered. In cases of blood-tinged hypopion, what should be our approach?
So blood-tinged hypopion is very rare. So unless there's trauma with infection, I can't think of blood-tinged hypopion.
So the rubeosis is chronic uveitis. Sure. Rubeosis can produce that kind of blood-tinged hypopion. Herpes zoster in AIDS patients I've seen. Right. I have reported also blood-tinged hypopion in herpes zoster in HIV positive patient.
So Dr. JP is an encyclopedia. No, I just recall even in HSV also you can, very chronic HSV can have blood-tinged hypopion. I did have one patient like that, and patient with rubeosis for any reason and having low-grade anterior uveitis. So we had one patient who had ocular ischemic syndrome. So I don't know if we can think of any other causes of blood-tinged hypopion.
You're correct.
Mostly it is viral. So yeah.
Another question that I would ask is that, so would we also see pigmented hypopion in B-dump cases? Like there was a patient who presented to us. So do you think that, Somasheila ma'am, you can take that till sir comes back, that will we see pigmented hypopion in B-dump cases?
Yeah, I think B-dump cases also, that is one of the differentials for pigmented hypopion.
Right. Because recently we saw one case which was being treated with methotrexate for a very long time and presented with pigmented hypopion.
You might want to tell what is B-dump.
Bilateral diffuse uveal melanocytic proliferation.
That will be too much for the postgraduates, I think.
Right.
That's going to be a bouncer if it comes. So the last set of questions, it's always nice to hear from you, Dr. Somasheila ma'am. Is it necessary to do HLA-B27 and MRI of SI joint routinely in every case of fibrinous anterior uveitis in young adults, even though no history of joint complaints?
There may be two schools of thought. I'll tell you my school of thought, but first I'll just tell you about the DUET algorithm. So there's a very good publication in which it gives you the DUET algorithm, D-U-E-T, which talks about what you should do if you have a patient coming to you who may or may not be HLA-B27 positive and who has anterior uveitis, and how do you determine that the patient could be or could not be. So to answer the question quickly, when I have a patient with non-granulomatous anterior uveitis in a young male and even sometimes young female patient also, I do HLA-B27 testing for these patients, even if they have no symptoms. The reason for me to do that is that you can write, so there's this is one test that has a high sensitivity and specificity for the disease. So it's a reliable test, in other words. If you're able to get positivity, it means that you have an etiology for the patient. And you know exactly how this disease is going to be, because all of us are very familiar with treating it. So we don't have to search for anything else. We'll know why the patient will have a recurrence. So that's the reason for me to do. And also we can caution the patient that you may have certain systemic symptoms. So watch out. Abhilasha, you already said that a small section, maybe 10-15% of patients come to us first and then start developing the systemic, or they may ignore it. They may not pay attention to it. So definitely it's important to do that first. But if I have a patient who's not at all affording, and financially also it's a little expensive test these days, of course, patients do afford, but that's the only reason. If it's a cost issue and I'm not able to get it, then I'll skip the test, but otherwise I get it for all patients in that age group.
And in the initial stages, when you're screening, it may not, MRI is not necessary.
Oh,
you
yeah,
can even get an X-ray done
I
of the
wouldn't-
sacral spine.
I wouldn't do that at all, because my part is to evaluate the patient and treat the patient for the uveitis. So if I have an idea that the patient may have some joint inflammation because of symptoms, I would refer the patient to rheumatologist, and so that the patient understands the two situations, that HLA-B27 can cause systemic disease as well as can cause ocular disease. So instead of me asking that, I think that investigation can be done by the rheumatologist, and it doesn't improve our specificity of diagnosing the disease. HLA-B27 is enough for us to get a positivity. We don't need the other tests.
I also don't do the MRI of the back or lumbar spine, or even X-ray lumbosacral joint also I have not done cases. I refer them to the rheumatologist to decide, because some of the patient may have backache, but that can be by exercise itself that can get rid of this backache. It may not really account for getting an invasive test done.
The question was that in all patients with young male patients who come in with fibrinous or non-granulomatous anterior uveitis, do you test for HLA-B27? Even
yes, and MRI. They are even asking about MRI. Should you also?
I don't do that.
Yes.
I don't do MRI.
Or even X-ray.
I don't do the X-ray also.
Yes. So the last question for the day: in Fuchs uveitis, I have encountered patients having AC cells and no cataract or CME quite often. Should I just keep on observing or start topical steroid? JB sir?
I'll keep observing, or I'll put non-steroidal anti-inflammatory agent.
Same. Steroid should be avoided.
Yeah.
Sometimes I might do, so these patients sometimes have a crop of, suddenly they'll have a crop of inflammation or slightly increase, a lot of ketic precipitates and slight increase in the vitreous opacities. So I do give one round of topical steroids, so they reach a baseline of very low level inflammation. If they are at low level inflammation, I don't treat them at all.
Yes. So this is the last question for the day. And sir, would you like to add anything overall on anterior uveitis?
I would say the anterior uveitis don't think so simple. And another important point is that all anterior uveitis at the earliest opportunity do a thorough fundus examination, should not miss an ARN, should not miss a toxo, and shouldn't miss a kind of a other retinal lesions like that focal tuberculosis of the choroid, like miliary tubercle of the choroid or tuberculum of the choroid. So earliest opportunity you see the fundus.
Right. I actually have a question for all of you, rather, that when you start off on immunotherapy, or like, when you're adding immunomodulation as a part of your treatment protocol, do you like to initiate the treatment on your own, or you prefer the rheumatologist's treatment, or you prefer to go in a sync? Because I've seen that the rheumatologist has a different opinion as how the ophthalmologist would like to proceed. So what is your preferred practice here?
I don't send routinely to rheumatologists for all my cases to start immunosuppressive therapy. I can take a decision on my own. What rheumatologist or internist does that one, they do the liver function test, they do the renal function test, they rule out infectious etiology like tuberculosis. And I can do the same for this one. So as an ophthalmologist, as a medical student, I learned all these things, and I can do the thing. But if the patient has got some rheumatologist issues like joint pain, backache, or juvenile idiopathic arthritis associated uveitis, which requires counseling as well as the treatment, so I send them to the rheumatologist, but not routinely. Intermediate uveitis case, which requires immunosuppressive therapy, I don't send it to internist or rheumatologist. I get the workup done and myself start the therapy.
Right, sir. Somasheila ma'am and Abhilasha ma'am, is that the same for you both as well?
Yes, I am happy to say that I follow exactly what Sir has said. So I refer to the rheumatologist only when they have some rheumatological problem, and otherwise for ocular inflammation, I manage the cases myself and monitor them. So it is much easier to monitor because the patient has an eye disease and your treatment should be titrated according to the response.
Yes, exactly.
So rheumatologists might feel lost in managing our cases.
We have a physician team on board, so we usually get a baseline workup done by them and a clearance, so they examine the patient. And sometimes the patient may not reveal certain history, say urinary tract infection or some other skin disease that they may be infected component. So they may not reveal it to us because they're ophthalmologists, so they feel hesitant. They might reveal that to the physician. So we just get an initial clearance done. And in between, if the patient has any problems or side effects, so the physicians help us out. And the patients who need rheumatology help, exactly if they have systemic disease, or if I need to treat them with either one of the biological agents, or the patients are not getting better despite our therapy, and then we want more help. So that's when I refer to rheumatologists. But these are rheumatologists with whom we have a close connection and we keep talking to them. We have a dialogue. Otherwise, yeah, otherwise it'll be the same story if you send to rheumatologists. They may not know what you want, and they may just start with the least effective for us therapy or the least harmful for the patient, which would be like a DMIARD, the DMARD.
Yeah.
Help us for our disease control.
And the patient in the whole process gets a little lost about what's going on as well. Yeah. That's absolutely right.
So over to you, Rolika. Thank you, Dr. Somasheila, for the excellent presentation and a very healthy, we had a very nice discussion. And thank you, Dr. JB sir, for the important pearls like every week. And over to you, Rolika.
Right. Thank you so much. And thank you everyone for making iFocus such a, huge help for the postgraduates. I must say that in 2022, we have had, starting from July 2020, of course, but we have had a great run, and 2022 has been good. And approximately like 120 plus episodes have been there this year. I hope they have been helpful to all of you, because they have been helpful to me as well. So while we are listening to everybody and all the legends in ophthalmology, it has helped us. And I can vouch for it that the lessons learned over here in the lectures, I'm able to put to practice in on my daily basis. So I hope that it helps all of you as well. Thanks a lot for taking out time for us. And as I said, that ma'am has been the showstopper for our 2020. We have with us the opening batsman of the next year as Jyotirmay Biswas sir. And he'll be talking on intermediate uveitis on Jan 6th. And so we're looking forward to
Jan 4th.
Jan 4th. Right. Sorry, my bad. So it's Jan 4th, and we're looking forward to having all of you as the first lecture of 2023. And of course, I don't need to mention and put up the slide again, but iFocus Physical, we have only few slots left now. So please enroll if you are interested. And if you have any questions, you can always message us and contact us. So thanks a lot to all of you. A very, very, very happy new year and a happy old year. So cheers to what has been and cheers to what will come.
Happy New Year.
Thank you. Just to say that we have a uveitis subscription course from LVP as well, but that's a paid course compared to the free one that you're attending right now. But that has some other aspects of uveitis, so that's for the really seriously interested people. The new course, starts with the new year on January 6th. So if you would like to, you can also join there if you really want to branch out and just about soak in every uveitis that you can get. So iFocus and then LVP uveitis as well.
Absolutely, ma'am. Thank you so much. Thank you, everyone. Have a very good night. And a very happy new year to all of you.
Thank you. Thanks for having me. Bye, everyone.